All right, Jenny, do you want to go ahead and get started?
Sure. So welcome you all. So thank you so much for joining us today. We're going to be doing a quick imaging review.
I actually can't hear you. I don't know if there's an issue with the audio on my end.
Huh.
I can hear just fine.
Oh, okay.
Jenny, is your audio working?
Yes, it is.
Yeah.
Okay.
Dustin, it's probably your headphones.
Can I get some notices in chat if people can hear either me or Jenny? You can hear both of us fine. Okay.
Okay, that's good. That's good. Okay. So I can, all right, so I'll go ahead and get started. So we're just going to go through a quick imaging review, specifically looking at the X-ray and CT images that will be on the exam. So there's always, it's high yield in the sense that there's always a couple of the images on the exam, which means that they're pretty easy points, as long as you're familiar with the images. And that's what we're gonna try to help you guys out with. Jocelyn, can you go ahead and click to the next slide? Okay. How do I do a thumbs up? Let me see. So in terms of orientation, I think what's always a little difficult about images is that everything's kind of reversed. You just have to imagine that the patient is always facing you. So the patient's left is going to be on your right and vice versa. Next slide, please. Okay, so I'm going to be covering some of the anatomy basics, and then Jocelyn will be walking you through the more specific images that are taken from the iBook.
I'm actually.
Oh, can you hear me now, Jocelyn?
Sorry.
Oh, go ahead. Sorry for the delay, guys.
Anyone else wants to try sharing? Sorry for the audio issues.
Okay, Jocelyn, how about I share?
Is it working?
Okay. Hold on, guys. Let's see if this works better.
I'm sorry about the audio issues.
Oh, hold on. I have to log in as
I'm just going to switch headphones and see if that helps. Sorry about the delay.
chooses the perfect.
I think I can hear you now.
Okay, you can hear me now? Okay,
yes,
perfect.
Okay, I think my sound issues are fixed.
Okay. Okay, do you want to go ahead and share the presentation again?
Sure.
Okay. Yeah.
So sorry about the audio issues, everyone.
No worries. So I'm just going to walk through that anatomy basics. So I feel like for anatomy, it's always helpful to link structure according to function. And specifically for the thorax, you can sort of look at how the blood is flowing. So you can click on the next slide, Jocelyn. Mm-hmm. Okay. So fortunately, the thorax is fairly simple in terms of there's not too many structures to think about. And what I like to do is I like to start with the circulation. So going from starting with the venous circulation, we have the superior vena cava and inferior vena cava, which join to flow into the right atrium, then to the right ventricle. And keep in mind, this is deoxygenated blood. And then the blood goes out through the pulmonary arteries to the pulmonary capillaries in the lungs, and then back through the pulmonary veins, which are oxygenated, to the left atrium and the left ventricle, and then out through the aorta. So from the aorta, you have sort of two parts to the aorta. You have the ascending aorta as well as the descending aorta. The ascending part branches out into the left and right coronary arteries, which supply blood to the heart. And then for the descending aorta, that splits off into the brachiocephalic, the left common carotid, and the left subclavian, which collectively supply blood to the upper half of the body. And then the descending aorta, which is outside of the scope of the exam, eventually splits into the common iliacs, which supply blood to the rest of the pelvis. All right, so that's it for anatomy basics.
All right, so now let's jump into the iBook. So on this upcoming exam, you're going to be responsible for sort of 2 chest x-ray views and for 6 sort of cross-sectional CTs. So let's get started with the x-rays. Okay, so there's a lot of things going on here, but one thing to keep in mind is that an x-ray is a 2D representation of a 3D image. So you're going to have a lot of different structures from different levels, from anterior to posterior, sort of superimposed on top of each other. So to sort of, I think whenever you look at these pretty complicated images, it's good to start off with something that's pretty basic. So what are easy structures to identify? And for me, that's often bones. So we can tell that there are some ribs here, right? There's some ribs that tend to look a little bit straighter. And then if you look even more carefully, there's going to be some ribs that sort of wrap around and are kind of curved, right? So it's pretty clear that we're seeing 2 different views of the ribs in the rib cage, right? Because as I stated earlier, this is a 2D representation of a 3D image. So how do you know which portion of the ribs is anterior and which one's posterior? Well, I have a little bit of a hint. Okay, so the more curved ribs that you see here, that's these guys, those are going to be anterior, and the posterior ribs are going to be the straight ones. Okay, let's move on to our next bone. So you can tell that the posterior ribs, if I bring that back up, articulate with the vertebrae, right? So let's look at some vertebrae. We can sort of see them pretty clearly here at the top. Can everyone see my mouse as I sort of go through this?
Yes.
Okay. So we have the vertebrae, and then you can just barely see them as we progress to the bottom of the image. Okay, so those are your vertebrae. And then does anyone know what these bones are? They're right here. Those are going to be your clavicles. And those are going to articulate with your sternum at the front at the sternoclavicular joint right here. It's pretty hard to see the sternum here, but you can appreciate that you have your left clavicle and your right clavicle. Another good thing in general to keep in mind when you take these images is the positioning of the patient. So for this image, it's pretty straightforward. It's like a pretty straight chest shot, right? And you can tell that this X-ray is sort of even and balanced because these two clavicles are the same size. And the last bone that you're going to be responsible for on this exam is going to be the scapula, right? So you can see one scapula, I'm sort of outlining it here with my mouse. So that would be your right scapula, and you would have another scapula here on the other side. All right, so let's move into some fun clinical correlations. So if your scapula sort of leaned this way, right, it would be leaning medially. What sort of process do you think would have caused this? Well, medial scapular winging is going to be caused by paralysis of the long thoracic nerve, which results in dysfunction of the what muscle? Of the serratus anterior, right? And that's going to be your stab wounds, trauma, that sort of thing. So if the scapula were to deviate in the other direction, say it were to deviate out here, that would be your lateral scapular winging. And generally that's caused by damage to the spinal accessory nerve, which is CN11, or the dorsal scapular nerve. And the muscles that are paralyzed in that case would be the rhomboids, right? So remember, the lateral scapular winging is going to be those two nerves, the cranial nerve 11 and the dorsal scapular, and the medial winging here is going to be your long thoracic nerve paralysis. That's pretty high yield for this exam. So now that we've covered bones, let's jump to organs. So the easiest organ to see probably on the scan is this right here. It's right in the center of your chest. And that's going to be your heart. So we can sort of, as Jenny did a great job of describing earlier, we have the aorta that comes off the heart, and you can sort of see that it loops down, right? And then it continues downwards like this. And this right here is going to be that aortic bump, right? And then we can follow the descending aorta all the way down, and then, you know, further down it'll bifurcate and form some of the lower extremity arteries. So one thing that's really interesting about the heart is that I'm just going to tell you that this border right here is your left ventricle. This border down here is your right ventricle. And this border right here is your right atrium. Okay, so that's a little bit complicated. So I actually have a little demo that I want to show you guys to help get this clear in your head. So Hallmark might have you believe, just imagine that this is your heart. This is your right atrium, this is your right ventricle, this is your left atrium, and this is your left ventricle. So Hallmark might make you believe that, you know, your heart sits just like this in your chest, and your atria are up here and your ventricles are down here. But that's not exactly true. That's not precisely true. Your heart sort of sits, you know, it's more flat like this. And then the apex, the ventricles are sort of pointing to the left and a little bit down. So this is really what your heart looks like in your body, right? So as I stated earlier, if we're going to follow, this is the right ventricle. Can you guys see like my little mouse thing? Okay. So this is your right ventricle. That's the right, that's why the inferior border is going to be the right ventricle. This up here, this yellow portion is your left ventricle. So does that sort of make a little bit more sense why the left ventricle would be this entire left border? And then your right atrium, which is this portion up here, is going to be your whole right border. And the reason why you're not really seeing the left atrium is because, you know, you have all your different, you have like the aorta, you have like all these different structures in the way, and it's also pointing kind of posteriorly, so it's really hard to see. So remember what the borders of the heart are. Right atrium, right ventricle, left ventricle. Okay. So one of your other clinical correlations is cardiac tamponade. And you guys aren't responsible for knowing what that looks like on imaging, but for those curious and for the MS2s in chat, we would have a water bottle sign. So the heart would sort of widen a little bit, and it'd be harder to see sort of this gap, this point between the diaphragm and the heart. So I sort of gave away the next structure, which is the diaphragm right here. So these two sort of bumps are sort of the structure, show the structure of the diaphragm. Okay, let's move on to the trachea and the lungs. So the esophagus, I'm just going to briefly mention the esophagus. The esophagus is this sort of like grayish structure that you can see descending here. And then the trachea, remember the trachea is always anterior to the esophagus. The trachea is harder to see, but that's going to be in front of the esophagus, okay? And then the main stem bronchus, the primary bronchus here, is going to bifurcate into the left and right primary bronchus. And that point is called the carina, or the carina. I've never known how to say that. It's a little bit hard to see on this image, but you can just barely make it out right here. And the really important clinical correlation of this is that if you notice, the right primary bronchus is almost a straight shot going down as compared to the left bronchus, which comes off at a little bit more of an angle. So if you aspirate something, it's generally gonna shoot straight down the right side rather than going down to the left. Okay, so now we've broken down the structure of the lungs a little bit. We've gotten the left and right primary bronchus. They're going to branch into the secondary and sort of tertiary bronchi and bronchioles, and then, you know, get smaller and smaller until they eventually become the respiratory bronchioles and alveoli. So the point at which all the vessels and where there's sort of all the vessels from the heart enter the lungs is called the hilum, right? And that's going to be around here. Okay. And are there any more clinical correlations that I've missed? One other thing that's kind of fun to mention is that on X-ray, if you were to see sort of like these big bead-like structures on these ribs, like so, what would you think that would be? That would be a rachitic rosary, which is from rickets, which is deficiency of vitamin D. Mucosa really likes testing on that. Okay, I'm gonna check for any questions. Okay.
I have a question.
Sure.
Can you repeat about rickets? Did you say it had something to do with the spine, or is it just the legs?
Oh, so on the ribs, you might see these nodules on the ribs themselves. And those widened nodules are because your body is trying to build, it's trying to grow, right? So you have chondrocytes that are proliferating, but there's not enough vitamin D to sort of fasten down calcium and to turn them into real bone. So you have these sort of widened bead-like structures that are on your ribs that are due to the lack of vitamin D, and that would be rickets.
Thank you.
Okay.
Could you also repeat the difference between the trachea and the esophagus?
Sure. So on the next slide, I actually have some annotations of where all the major high yield structures are. But the esophagus, you can see, is sort of this darkened structure right here. That's the esophagus. And it's really hard to see the trachea on here. It's just sort of like this light hazy thing, but you can sort of follow from the carina up. So that would be the bronchus. It's really hard to see on this image. The last thing that I wanted to mention is that down here we have the coscophrenic angles in the lungs. And these are clinically significant if you have a pleural effusion. So if you have a pleural effusion, then if you can imagine, you know, if you're going to fill up a cup, if you're going to pour water into the lungs, the liquid is going to collect down here and it's going to blunt those coscophrenic angles. And, you know, if it reaches a high enough level, it forms something called a meniscus sign. And that's a sign of pleural effusion. And then, of course, you guys learned in anatomy that you would use like thoracocentesis to try to draw out some of that fluid. One other point that I can touch upon is lung collapse, which is another important concept in anatomy. The fancy word for that is pneumothorax. So there's two types of pneumothorax that you're responsible for. And the first one is the spontaneous pneumothorax. So what that's going to look like is that there's going to be, you're not responsible for how this looks on imaging. But basically, there would be some clearing of some of these bronchi because the lungs collapsed, right? So this space would be pretty dark because there's no tissue, there's no vessels sort of in that space anymore. It's just straight up air. So this is like a spontaneous pneumothorax, right? And then because that lung's collapsed, there's extra space in the lung cavity on that side. So the mediastinum this structure here is going to deviate towards that pneumothorax if the right side was collapsed. And then the diaphragm is going to move up on that same side. In the other case of pneumothorax, that would be your, not your spontaneous, but like the traumatic pneumothorax or the tense pneumothorax. Then what would happen is that, you know, like generally that's in patients with like a history of trauma, doesn't generally happen as spontaneously. There's going to be basically like a one-way valve that's formed between your lungs and the pleural. So there's sort of this really delicate balance between your lungs having a lot of elastic fibers in them, really wanting to collapse, and the chest wall sort of keeping that, like holding onto the pleural and keeping it straight. So if you interrupt that delicate balance between the lungs wanting to collapse and the pleura, sort of the negative pressure of the pleura keeping it in place, then the lungs are just going to collapse inwards. And that's what happens in these pneumothorax cases. So in the tense pneumothorax, what's going to happen is after every inspiration, some air is going to escape into that intrapleural space. So with every breath that you take, there's going to be increased pressure on the side of the pneumothorax. And that's going to push the mediastinum, that's the trachea, the esophagus, all of the heart, that's going to push all these structures off to the opposite side. And that's going to push the diaphragm down. So once again, the tension pneumothorax is the one that's generally caused by trauma. It's going to present with mediastinal deviation to the opposite side of the injury or whatever side had the pneumothorax, and the diaphragm is going to move down. And the spontaneous pneumothorax, those are generally in, you know, tall, thin men. Generally, no, it doesn't have to have a history of trauma. The lung is going to collapse inwards, which is going to result in less pressure, causing this diaphragm, the diaphragm on the same side, to move up and the mediastinum to move towards the pneumothorax. Okay, and I know that there are a lot of different clinical correlations, but those are most of the ones that you're going to be responsible for on this anatomy block. I'm gonna check the chat for questions again. Actually, I can't see chat right now. Okay, any other questions on this section before we move on? Okay, so moving on. We're going to be taking a little bit more time on some of the earlier slides just to get some of our fundamentals down. Yeah, so now let's take a look at the lateral view. So I'm going to be completely honest. You can see most of the same structures, right? So you can see like the esophagus coming down here. You can see the ribs, you can see the heart. But the only structure probably that they're going to ask you to identify is the difference between the left and right lungs. And that's, there's a gastric air bubble underneath your left lung. This is pretty easy to remember because your left lung is smaller than your right lung. So it's going to be the one that has the gastric air bubble on it, which makes it look sort of like it's even smaller. So this lung right here is your left lung. This lung is going to be your right lung. And this was the only point that was highlighted in the iBook. So I think laterally, that's probably the biggest thing that you should be aware of. It's one other thing, one really short point. As stated previously, the left lung is smaller than the right lung. So it's pretty easy to remember that the left lung is going to have two lobes, superior and inferior, which are separated by an oblique fissure, and the right lung is going to have three lungs. So the superior, the middle, and the inferior, right? And it's going to have both an oblique and a horizontal fissure. Okay, moving on, really the only important point on the lateral X-ray that I want to highlight is the gastric air bubble under the left diaphragm. Okay, so is everyone feeling pretty comfortable about the X-rays?
Which one's left and which one's right again?
Sure, so the left diaphragm, the left lung is going to be the one that has the gastric air bubble underneath it.
Okay, so
right?
it's like the
So the left lung is smaller.
Okay, that sounds good.
Okay. All right, so now let's move on to the CTs. So I think that the easiest, one of the most important things to identify in every CT scan is what level you're operating at. Because it's pretty hard to identify vessels just by looking at them because, you know, vessels are just circles, right? There's nothing really that you know, if you just isolate these few pixels by themselves and give them to me, I won't be able to tell you what vessel it is. Instead, what you do is you try to figure out where you are in the chest and the mediastinum to then sort of back solve and figure out what vessels sort of go through that area. So the way that I like to separate the different structures in the iBook is like so. So I think that there's one pretty clear cervical / neck area where you can see like the thyroid, and you can sort of see these clavicles. There's one section above the aortic arch. There's one that's at the level of the aortic arch. There's one that's right above the heart, and we can identify it with the pulmonary arteries. And then there's one that's at the atrial level. And then the last section that we'll look at is going to be at the ventricle level. We're going to look at these all in more detail. So let's start with the cervical section. So I think it's easiest to start off with structures that are easy to identify, namely the bones, right? So first things first, we have a vertebrae here, right? And then you guys should know the different parts of the vertebrae. So this would be the body, right? This would be the spine. This would be the transverse process. We have the spinal canal. And then we have the pedicles and the lamina, right? So we can identify all of those on this vertebrae. It looks like we have some two little rib-looking things coming off of it. And then what bone do you guys think this is? Remember, we're sort of at this level right here. So at this level, we're sort of catching just the very back of the clavicle. So the clavicle is going to sort of travel forward more here, and we're just catching the very end of it. And then what bones do you think are here? Keep in mind that for this, the patients are sort of positioned like this. So if the scan is taken at about this level, what bone do you think that is? It's going to be the humerus, right? So the reason why there's this sort of brown space in the middle is because I think in block 1 you guys learned about the difference between cortical and trabecular bone. So this is sort of the hard outer trabecular cortical layer, and then on the inside you have the spongy bone. So those are sort of our main bone structures, right? And then just by identifying the clavicle, you already know what level that you're at. You already know that you're sort of in this area, you know, the heart's down here, you know that you're above the heart. You're not really getting any of the really, really big, like aorta, you're not getting any of the really, really big vessels. So now we have to sort of wade through the harder part, I think, which is identifying some of these major vessels. Actually, I think the easiest way to do this would be like this. This is what I'm going to do. So right now, we are above the level of the lungs. We're above the level of the heart. We're sort of up here, right? So what vessels are we expecting to see? So we're expecting to see the left and right common carotid arteries, right? And those are going to be these two right here. But what veins are we going to see? So the left and right, so the way that the arteries bifurcate is we have the common carotid arteries break off, and then from here they'll go into the left, the internal and the external common carotid arteries. I'm sorry, the internal and the external carotid arteries. And then we have the subclavian coming off here, and then we have the vertebral coming off of the subclavian like this. On the veins, it's a little bit different. We have the same, you know, basic vessels. So I think the jugular and the carotids sort of go together. And then they come off in the order of VIES. So you have the vertebral artery that sort of comes off first of each brachiocephalic vein. Then you have the internal jugular vein, you have the external jugular vein, and then you have the subclavian vein that sort of comes off and goes like this. I have like a little picture here, right? So we have on the venous side, we have the vertebral, the internal jugular, the external jugular, and then the subclavian. So what are we expected to see sort of at the neck level? We're not really expecting to see any of the subclavian veins because they've sort of gone over to the side, but we are expecting to see possibly like the vertebral vein, the internal carotid, the internal jugular and the external jugular. So this right here is going to be your internal jugular vein. Your external one is going to be out here, right? And then your vertebral vein and artery are probably one of these guys. These guys are not, you're not responsible for these on your exam. If I don't highlight them in the next slide, then you're not responsible for it. So far we've identified two sort of out of these three structures. And then this last structure right here on either side of your neck is going to be your thyroid glands. right? And then in the middle right here, this big hole is going to be your trachea. This picture, your esophagus comes right behind your trachea. It's really hard to see in this picture. It's probably just smushed closed. But this picture is mainly just to show you those three structures: the internal jugular vein, the common carotid artery, and the thyroid gland. And those are going to be sort of like the three sort of hard to identify little structures that are right next to each other, right? So I've inked all of these structures on this slide so that you can see them more clearly. You have the thyroid glands on either side. You have the common carotids left and right, and you have the right internal and external jugular veins. Does that make sense to everyone? Okay, so once again, we want to identify the cervical section by just making sure we see the clavicles and the humerus. And remember, the patient's going like this. So the top CT is going to have the arm. Okay, sound good? All right, let's move on to our next scan. Okay, so now we're at the right above the aortic arch. I'm just going to put that image back just because I liked going through this. So right now we are right above the aortic arch. What sort of vessels are we going to see? So actually, like first let's just knock down some osteology. So this is going to be the very front of your chest, and that's going to be the manubrium of your sternum, right? Your sternum's right here. And then what do you think these are going to be? These are going to be your clavicles, because your clavicles, remember, articulate with the very top of your sternum. So these right here aren't vessels, these right here are bones. You have some ribs coming off here, and then you have scapula. Okay? And then what do you guys think this is? These dots right here. Well, if you remember back to the osteology, we have your scapula have something called a spine, right? And then that's really important because that sort of separates all your rotator cuff muscles out. So just a really quick review of your rotator cuff muscles. You have your supraspinatus. I like to remember with a mnemonic sits. So you have supraspinatus, infraspinatus, teres minor, and subscapularis. And the only one that's going to be riding above that spine is going to be the supraspinatus, right? And remember that the supraspinatus tendon is the most common one injured, right? So most common rotator cuff injury is injury to supraspinatus tendon. That's another one of your anatomy clinical correlations. Okay, so with that aside, we now have identified most of the bones. Once again, we have the vertebral body here. One other thing to note is that as we get further down into the thorax, the bodies are going to get larger and larger. The bodies of the vertebra are going to get just a little bit bigger. If you go back to the previous slide, this body is going to be a little bit smaller, which is another tip that's sort of more in the cervical-ish region. And then we have two more sort of ribs coming off. These are all sort of like pieces of your ribs. As another review, I didn't mention this before, which is sort of an oversight by me, but when you take CTs, structures with greater density are going to show up brighter. So the really bright structures are very dense, and those are going to be your bones, right? And then after that, you're going to have the muscle, which is sort of the structure, which is just a little bit denser than the fat or adipose tissue, which is here. Okay, and then air is the least dense of all, which is going to show up as black. The reason why some of these vessels are going to appear white is because they've had contrast injected into them. If you see this on a patient without contrast, then these are also going to look dark. Then the inside of these vessels are also going to be dark. Okay, so now that we've knocked down the bones, now we have a few vessels to identify. So we have these three vessels that seem to kind of go together, and then we have these two vessels. So now I'm just going to throw down that anatomy picture so that we can get a better idea of what vessels those might be. So these three vessels, do those kind of look familiar? So those correspond to the three different vessels that are coming right out of the aortic arch. So we have the brachiocephalic artery, the left common carotid artery, and the left subclavian artery, right? So now passing just anteriorly, what do you think the next vessels are going to be? They're going to be the left and right brachiocephalic veins. So this is going to be your right brachiocephalic vein. That's this one. And then this one looks a little bit funny because you're catching a cross section, but that sort of matches what we're expecting to see, right? So this is going to be your left brachiocephalic vein. Okay, and then once again, we can see the trachea. We also know that this level is pretty high because the trachea hasn't bifurcated into left and right yet. We're still above the level of the carina, right? We have the esophagus. Looks a little bit funny, but that's because, you know, your esophagus doesn't really have any, the esophagus doesn't have cartilage like your trachea does that keeps it open. It can kind of flop closed. So this esophagus is sort of a little bit floppy and closed, right? And I think those are all the major structures at this level. So I've highlighted all of those structures again here, right? So you have the sternum, the clavicle, in terms of the osteology, you have the ribs, you have the scapula, and then in terms of the vessels, we have the three big veins coming off of the aortic arch. Those are the brachiocephalic, you know, which has been going to, another name for this is the innominate artery, which is I think is kind of funny. And this is going to bifurcate then into the right common carotid and the left subclavian artery. And then we have, of course, the left common carotid and the left subclavian, and then the left and right brachiocephalic vein. I have a barky dog. All right, so that is the level above the aortic arch. And we want to identify that based upon, you know, the fact that we have the sternum here and we have the very end of the clavicle. Additionally, I think these three vessels are really easy to identify. I have to get my dog. Hey, Mochi. 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 All right, sorry about the dog interruption. So now we are level with the aortic arch. So previously we had these three big veins that were coming off of the aortic arch. Now let's take a look at the aortic arch itself. So this is going to be the aortic arch, the structure right here, right? And then once again, we have the trachea, and then we have some other vessel here. So right now, we are still superior to the heart. So what big vein are you going to expect to see? Are you going to see the superior vena cava or the inferior vena cava? You're going to see the superior vena cava. Okay, and this right here is another vein that looks like it's emptying into the superior vena cava. What do you guys think that is? This is going to be the azygous vein. And if you guys remember from anatomy, the azygous vein is going to be collecting all of the flow from the sort of like the rib region below it. And the reason why, and specifically it's collecting like all the costochondral venous flow on the right side, right? And on the left side, you have like sort of a bunch of different azygous-like veins that fulfill that purpose. Like we have the left superior intercostal, you have the accessory hemiazygous, you have the hemiazygous, and you have like the ascending like lumbar vein. You have like a bunch of different ones. So the azygous vein is the vein that collects like all of the venous blood flow from like the rib area and dumps it into the superior vena cava. And one reason why this vein is so clinically significant is because it represents an I don't even know how to say this word, anastomosis from the superior vena cava to the inferior vena cava, because it runs the whole length of your right side of your body, from like here to like all the way down to your IVC. And that's really important because if you have a blockage in your IVC region, this is like a clinical correlation from your iBook, then your body can sort of use the azygous vein as another accessory pathway to get into your superior vena cava. So that's the azygous vein. Another thing to keep in mind is that we see the scapula again here, right? And then this time, we saw the spine in the last slide. So now we are below that spine and we're getting into the rotator cuff muscles that are below the level of that spine, right? So that would be your infraspinatus, your teres minor, and your subscapularis, right? And it's hard to really differentiate which muscles those are, but your subscapularis is going to be like sort of the big one that sits on top of the other three, the other two, and then that's going to be about right here. Okay, I think those are all the structures in this region. Yeah, just about. And then this sort of funny cone thing here is just an artifact from the way that the image was taken. Okay. And I think those are all the points on this level, so we can keep on going further down in the heart. Okay, so now we are just above the heart. And how can we tell that we're just above the heart? We can tell because the presence of these major arteries right here, right? So I'm actually gonna throw, I like this picture quite a bit, so I'm gonna put this picture back, right? So the previous picture was right at the level of the aortic arch. Now we've progressed to just above the heart. So what are we gonna be seeing? We're gonna be seeing the pulmonary arteries, for one, and then we're gonna be seeing the root of the aorta, right? So here is the pulmonary artery. That's sort of bifurcating into left and right pulmonary artery, and then here's the aortic arch. So let's see this in the big view. So this is going to be just the root of the aorta, right? So if I took off the labels of this image, right, and you had no idea where this picture was taken from, would you still be able to tell left from right? And the answer to that is actually yes. And the reason why you can tell is because the pulmonary arteries, the left and right pulmonary arteries, pass in different ways over their respective primary bronchi. Okay, so in this image, which direction is left and which one's right? So remember that we're taking these CTs, imagine like looking from the feet up, right? So this would be, so we're looking sort of down and through the feet, upwards at the patient. So this would be the right side of the patient, this would be the left side of the patient. So the left pulmonary artery is always going to pass superior to its primary bronchus, the left primary bronchus, and the right side is always going to be anterior. So you can see that if this is anterior and this is posterior, this pulmonary artery, this right pulmonary artery is passing anterior to its primary bronchus. So that's how, even if this slide got, turned around or flips upside down, how we could still be able to orient ourselves. We can follow the path of the aorta too. This is the sort of root of the aorta, but it's going to come down and descend on the opposite side. So this is going to be part of the aorta, right? So this is the trachea, the esophagus is going to be just behind it, and then we have the esophagus vein. Remember, the esophagus vein is running up and down sort of your rib area, and then it's going to dump into the SVC. I think those are the main things that I wanted to mention at this level. Did I miss anything? No. Okay, so does that sort of make sense? Oh, this of course would be the superior vena cava emptying into the heart. So the heart's going to be just below this structure. Okay, so those are our main structures just above the heart. So now let's get to the atria level. Okay, so once again, we can use osteology to orient ourselves a little bit. We have just a little bit of scapula left. And if you remember, your scapula are sort of like triangles, so it makes sense that the scapula are sort of getting smaller as you go down. Conversely, the lungs are sort of thinner at the top and wider at the bottom. So it sort of makes sense as we go through these slides that the lung spaces are getting bigger. So let's just try to orient ourselves and look at the chambers of the heart. So we sort of have three major chambers, 1, 2, 3. So how do we know which ones they are? So I said that this was at the atria level, but I have 3 different chambers. And the way that we can tell is that the right ventricle, remember, the right ventricle is always going to be the most anterior, right? Like remember, we have the heart, we have the heart that's sort of like this. The right is always going to be the most anterior. So this is going to be the right ventricle, okay? This is going to be the right ventricle, and this is the right side of the image. So this is going to be the right atrium, and then we have the left atrium down here. Once again, we have the, okay, and then once again, we have just the root of the aorta that's coming off of this, right here. And then we're going to have the azygous vein here, the descending aorta here, and then the left inferior pulmonary vein. So this pulmonary vein is sort of pushing out into this left lung, right? And then here you can sort of see, like, vaguely, you know, the bronchus that's sort of branching out. So those are actually all the main structures at this level, right? And then as stated previously, you can notice that the base of this vertebrae is going to get a little bigger. Okay, so in all of these slides, I've sort of highlighted all of the structures that you're going to be responsible for on the exam with ANC, right? So once again, we have the right ventricle, the right atrium, and the left atrium. Okay, last level. We're nearing the end of this. So at the level of the ventricle, what do you think this is? Once again, it is the most anterior chamber, right here. That's going to be your right ventricle. Okay, so this ventricle here is your right ventricle. And this, so if this is the right ventricle and we're at the ventricular level, what do you think this is? This is going to be the left ventricle and is going to be separated by the interventricular septum. Okay, you can sort of see a little outline of some tissue here, right? So that would be the tricuspid valve. Remember, what valve separates right atrium from right ventricle? That's going to be the tricuspid, right? And then on the opposite side, you can't really see it here, but the opposite, the corresponding valve would be the mitral valve for the left atrium emptying into the left ventricle. Remember, the left atrium is going to be the highest structure. It's sort of the most superior, so you're not going to see it in this scan. Okay, so these vessels are going to be the same vessels from following down from the atrial level, right? So we have the descending aorta, we have the azygous vein, and then we're going to have the esophagus, right? So if you remember from this slide, we had the esophagus, the descending aorta, and the azygous. There's just the same here. So this is going to be the esophagus. Looks kind of weird because it's sort of squished closed. We have the descending aorta, and we have the azygous. And what do you think this is going to be? What sort of large, we already identified the aorta, right? So what big vein is going to be below or sort of at the bottom of the heart? Previously, we had the superior vena cava. So this one is going to be the inferior vena cava, right? And those are all the structures that you're responsible for at the ventricle level. So hopefully now that we've gone through all of these different structures, you're a little bit more comfortable with what these scans look like. So hopefully this isn't so scary anymore. So now let's try to identify what levels these are at without the labels. Okay, so let's try the cervical level. Which one's cervical? What are we looking for? We're looking for the scapula, we're looking for the humerus, because remember the patient is like this, right? So here it is, this is the cervical level. We have the scapula, we have the humerus, and then we have these vessels. Remember these vessels, we have the internal jugular, we have the common carotid, we have the thyroid, which would be enlarged in what? That would be enlarged, it would be a goiter, would be an enlarged thyroid, and you would get that in iodine deficiency, or you would get that in Hashimoto's thyroiditis. And you have the trachea, right? So those are most of the big structures for the cervical section. Okay, so just below the cervical section, we have just above the aortic arch. So what structures are just above the aortic arch? Those would be, you know, the three big vessels that come right off of the aorta. And where are those? Those are right here, 1, 2, 3. So this is the structure that is just above the aortic arch. Another thing to keep in mind is that the top of the lungs, the apex of the lungs, is going to be smaller than the base of the lungs. So that's another really good hint to where you are in the chest. So, you know, once again, we have the brachiocephalic, we have the left common carotid, and we have the left subclavian, we have the primary, we have the main stem bronchus, we have the esophagus that's sort of squished flat, and then we have the left and right azygous veins. And remember, the reason why that left azygous vein is looking a little funny is because we have that cross section of it. It's sort of moving a little bit horizontal, right? And then we have the manubrium of the sternum, the two clavicles, and then the spine of the scapula. Okay, continuing our route downwards, if we are at the level of the aorta, where is that cross section of the aorta? That's right here, right? We're looking right at the level of the aorta. We have the IVC because we are above the level of the heart, and we have the azygous vein that's dumping its contents straight into that SVC. Okay, moving downwards just a little bit more, we are going to be right above the heart. We're going to be hitting all of those vessels that are just above the level of the heart, which are going to be your pulmonary arteries, left and right. You remember that your right pulmonary artery is passing anterior to its respective bronchus, and the left is, if you imagine the bronchus sort of going this way, the left is going to be superior to its respective bronchus, right? And then once again, you have the superior vena cava and the aortic arch. And then at the level of the atria, which is sort of like the top level of the heart, you're going to have the right ventricle, because you can tell because it's the one that is the most sort of anterior. You're going to have your right atrium, your left atrium. And then we can start following these three different structures, which are going to be your descending aorta, your azygos, and your esophagus. So moving down to the level of the ventricle, you can see those same structures again. You can see the descending aorta, you can see the esophagus and the azygos once more, and then you can see the two ventricles. Once again, it's pretty easy to tell which ventricle is which because the heart is going to be pointing to the left, so this is going to be your left ventricle, and then your right ventricle is always going to be your most anterior chamber of the heart. This vessel, of course, would be the inferior vena cava because we are approaching sort of from the bottom of the heart. Okay, so I hope that this rapid review has sort of made these scans seem a little bit less scary. Just checking for general questions. Does anyone have any questions?
Yeah, actually, you said something right at the
Sure.
beginning about the scapula and whether it's like kind of there was a clinical correlation about the scapula
Yeah,
and the
the
nerve.
winging of the scapula?
Yeah, it's very possible we covered that. Maybe somebody else remembers. I don't remember that from our. Anyway, I was just appreciating if you could go over it again. I don't think I got it the first time.
Oh, sure. So I actually am not 100% sure if you guys cover both types of scapular winging this early on. I think you guys for sure cover the medial scapular winging. So medial scapular winging, let me go back to that scan real quick. Okay, so here's your scapula. If it deviates medially, remember this is the middle, this is lateral, right? So if we're going medial, then there's generally paralysis of the long thoracic nerve, which is going to result in paralysis of the serratus anterior, which is going to cause the scapula to deviate in. And that's going to be your medial scapular winging. And this is generally caused by, stab wounds, injuries. These are actually more common. The other type of scapular winging is going to be the lateral scapular winging. So your scapula is going to come out like this. Okay, it's going to move away from the center. It's going to be more lateral. I'm pretty sure you guys have talked about the spinal accessory nerve before, but I'm not sure if you guys have talked about it in terms of scapular winging. This might come back. This will definitely come back when you guys do your musculoskeletal block. But in this injury, generally it's like iatrogenic. So generally it's like a patient that's had a surgery or something, and that's damage to your cranial nerve 11 or your dorsal scapular nerve, right? And that'll cause injury to or paralysis of your rhomboid muscles, which will cause it to move laterally. So medial is going to be your long thoracic nerve and serratus anterior, and lateral is going to be either your spinal accessory or your dorsal scapular nerve and paralysis of your rhomboids. That answer your question?
It does, yes, thank you.
Okay, cool. Any other questions?
Question on that. Why does a lot of feedback? So when you do, sorry.
I'm not sure if I can hear you.
Yeah, sorry about that. I had it open on another device.
No
so
problem
when
at all.
It went crazy. I was saying, so the lateral scapular winging you said happened with the rhomboid. So that's because it's paralyzed. So the main function would be to pull the scapula medially then? Like
Yes,
as a
I believe. Yeah.
Okay, thanks.
Okay. Any more questions? Okay, so if there aren't any more questions, I just wanted to say that, right now you guys are probably all super stressed out and, the exam's just around the corner, but I wanted to state that everyone at AMS is really supporting you and trying to help you do well because, the end goal in mind is just to help people learn how to take care of patients really well because everyone just wants, their patients to be healthy and happy and do well. So you have so many people supporting you. If you need help, please, please, please ask for it. Your mental health is so, so, so important to us. My email's here for questions, but also if you just need someone to talk to or if you just want to reach out, please let me, your peers, the staff at AMS know, and we really, really support you. You guys are all superstars. I know you guys are absolutely going to kill it on this next exam. Every single time you see one of these images, it should be a freebie, all right? So, thank you so much for your time and, listening to me talk for an hour. And good luck on Friday. All right, so that concludes our high yield review. I'm just going to check chat really quickly. Okay.
Jocelyn, someone asked if the recording would be available.
Yeah, I'm trying to record it. Hopefully Zoom doesn't let me down. If not, then I will just send out the slide to everyone who wants it. And people can email me with any questions. All right, thank you guys so much for listening.